Hello friends, I am Dr. Harsh Mathur from Om Netralaya, Varanasi, India, and today I'll be discussing about this supracapsular technique in this young 37-year-old gentleman with a aim to perform the surgery while creating a Rhexis of between 5.25 to 5.5 mm. So by now the side ports are being constructed with this 20 gauge bent MVR, and look how phenocane works. The moment I inject, the pupil dilates nicely, and this much dilatation is good enough to perform phacoemulsification. The capsule is stained underneath the air bubble with trypan blue dye, and then the dye is washed off. Now 1.4% sodium hyaluronate is injected. Maintain the anterior chamber, and a triplanar incision, barely nicking the limbal vessels, is then constructed. It's a 2.8 mm steel keratome, and now the aim is to create a 5.25 mm of Rhexis. So the flap is created with the 26 gauge bend needle and with the Utrata forceps. A continuous curvilinear capsular Rhexis is made, and this should be around 5.25 to 5.5 mm. And now the important part, to do the hydrodissection and prolapse the nucleus. So excessive OVD is removed, and then the anterior capsular rim is stented upwards and a wave of fluid is injected. Do not attempt to prolapse the nucleus in the first go. Now the same is repeated from the other side. Now I'm trying to rotate the nucleus, and once I find that it's very soft and I'm not able to rotate, a continuous jet of fluid is injected. Keep injecting till one pole flips over. Now a bit of OVD is injected to protect the endothelium. Now this is such a soft cataract, not much needs to be done. This is Cataracts 3 phaco machine, and just by giving a bit of vacuum, the nucleus starts emulsifying, and in no time, there's no need to even chop this soft nucleus in this 37-year-old gentleman, and we are done with the nucleus. So it's always better to prolapse these soft nuclei out of the bag partially and then emulsify, because it's very difficult to hold these nuclei. So chopping is a tough task. They'll cheese wire. Even if you're going for a divide and conquer or a stop and chop, there's always a risk of going through and breaking the posterior capsule. So what I find is that tilt and tumble and supracapsular phaco is the way to go with these soft nuclei. So this method is repeatable and very easy to perform without risking the endothelium and the capsule. So this is a hydrophobic IOL. The anterior haptic is tucked in, and then the trailing haptic is gently dialed in. Once the IOL goes in the bag, you can see that the anterior capsular rim is nicely covering the optic. So it should be around 5.25 to 5.5 mm, nicely covering the entire 360 degree of the optic, which will give a long-term stability in this young patient. So in these soft cataracts, my way to go is this supracapsular phaco. Do let me know in the comment section what is your go 2 method in these soft cataracts in these young patients. So now the OVD is nicely removed from both behind and above the IOL. The wounds are hydrated and the case is closed. I hope you like this video. Do like and subscribe to my YouTube channel and help it grow. Gentle hydration of the roof is enough, and the chamber is watertight, and that's it. The IOL is nicely placed. Thanks for watching.